Thank you very much for that. It really is a great honour to receive this award, especially for me as a pathologist. To receive an award from an oncology organisation is really very special to me. When I was trained a long time ago in thoracic pathology, my mentor was very clear that it was very important for me to be aware of the clinical aspects of the diseases that I was dealing with, as well as the pathology. And so I've always been, or I'll always tried to be clinically aware of what's going on. And I think that's really important for a pathologist. And so it means really a lot to me to get this award from such an organisation. So I think the key points that I tried to emphasise in my talk accepting the Heine Hansen Award were really twofold. One was the influence that Heine Hansen had on certain aspects of lung cancer and its treatment, particularly in the arena of small cell carcinoma. And I'm old enough to remember Heine Hansen. I never met him, but I remember him from his work. My pathology teacher knew Heine Hansen and followed his work carefully. And the main point of my talk was really how lung pathology and diagnostics have evolved over the last 30 or 40 years, largely driven by therapeutics. So although we pathologists tend to concentrate on making a diagnosis, and sometimes that diagnosis is not necessarily very relevant for the treatment of the patient, but that has all changed in lung cancer particularly. That was really the story that I tried to tell over the course of my career. So at ELCC this year in 2025, there have been lots of very good presentations and studies. Of course, because there are parallel sessions, I haven't managed to get to everything, but I've attended a few. I think there are 2 or 3 areas that stand out for me for different reasons. In terms of therapeutics, obviously there's a lot going on with new drugs and new combinations coming along. And one of the standout discussions at this meeting has been the presentation of the Mariposa data, where lazertinib and amivantamab has been shown in first line as a combination which almost looks superior to osimertinib for EGFR mutated tumours, and probably also superior to osimertinib plus chemotherapy. So this is a new combination for our EGFR mutated patients, which is potentially very significant. There are issues with toxicity, and this was the subject of a great deal of discussion and also some clinical trials trying to ameliorate that toxicity. So that's one thing. We had a very interesting session on how artificial intelligence is going to impact on potentially all sorts of aspects of lung cancer care, including pathology. There's a lot of hype around this area. There's a lot of investment and money being poured into this. I'm sure people see lots of opportunities. Sometimes I get concerned about the rapid adoption of new technology, when really we haven't figured out the best way to use that technology, and is it really going to help us? It does look as if it will, but exactly how that looks remains to be determined, I think. But it's certainly very interesting and potentially very, very powerful work. The last thing, as always, and this is relevant to my area, the issue of delivering diagnostics was discussed in one of the sessions, and how we deliver diagnostics and especially genotyping in different parts of the world, especially in parts of the world where there are challenges around resources. I think sometimes we lose sight of the fact that not everyone can afford extensive genotyping, very high-end technology solutions, liquid biopsy testing. These are expensive tests, and they often deliver far more information than is actually required to treat the patient. And I sometimes feel, especially in places where resources are constrained, that those resources might be better invested in the simpler diagnostic steps, which can still deliver most, if not all, of the information that is required for the patient. Sometimes we lose sight of that simplicity.